When managing a patient with chronic myeloid leukemia, the appropriate timing for running a kinase domain mutation analysis would be at the time that a patient either misses a treatment milestone, so if their molecular testing results at a certain time point are not what we would expect or what we would hope, that would be an appropriate time to look at a mutation analysis, or in a patient who has previously met those milestones but then loses their response. That would be another time that you want to look at a mutation analysis. Doing it at the time a patient is diagnosed is not the time that we want to be looking, because the chances of finding a mutation at that point are extremely low. So we would just wait until a patient is not responding to treatment in the way that we would expect.
The standard monitoring of chronic myeloid leukemia has been done using PCR technology, and our goal with most treatments has been to get patients into a major molecular response or, if possible, into a complete molecular response. The currently available PCR technologies are usually able to go down to levels of 10 to the -4 or so, and are quite sensitive, and have shown that in patients where we can get a major molecular response or a complete molecular response, this does correspond well with a event-free survival in those patients. The digital process may be able to increase this by 1 log further. At this time, the clinical importance of such a deep remission is unknown, but I think as we're getting prolonged follow-up on these patients, what we are starting to see that it is really the patients who have a complete molecular remission that benefit. And so it is quite possible that using the digital method of PCR, we may be able to get a more in-depth look at a complete molecular remission that could result in a treatment-free survival. But these studies will take many years and long follow-up to be determined.
When I see a newly diagnosed CML patient and am trying to determine the most appropriate therapy for that person, I take into account a number of different factors. One being the patient's other medical conditions or comorbidities, the patient's age, the patient's SOCL risk score. We have good data that show that patients with intermediate and high-risk SOCL scores respond better and have better long-term outcomes when treated with second-generation TKIs. So in that setting, I would try to use a second-generation TKI as frontline therapy rather than using imatinib. If we have somebody with a low-risk SOCL score, and maybe, depending again on comorbidities, imatinib may be a better choice. So all of those factors have to come into play when trying to determine the most appropriate therapy to use upfront.
Upfront therapy in AML is a very interesting area. There are a number of options now available, which is good for physicians and the patients. At MD Anderson, our approach has been to use a second-generation tyrosine kinase inhibitor upfront. The data do show that the rates of major molecular remission as well as complete molecular remission at 12 months and 18 months are better using a second-generation tyrosine kinase inhibitor such as dasatinib or nilotinib in patients as compared to imatinib. At this time, there is no clear data showing that there is a survival benefit. However, in a disease such as chronic phase CML, where median overall survivals are above 7 to 8 years, it may just be a matter of time, and we need to continue to follow these patients. So what we recommend at this time is, when feasible and available, consideration of using a second-generation TKI upfront in treatment of new chronic phase CML. However, there's also data to say that when you use imatinib at higher doses, it may have equivalent response rates. There's never been a head-to-head study comparing, for example, imatinib 600 or 800 versus dasatinib or nilotinib. So we still think that the second-generation TKIs are probably slightly more effective, which may in the long run result in a overall survival benefit. One new approach that we are pioneering in a clinical trial that we're doing at MD Anderson is whether we can use these second-generation tyrosine kinase inhibitors, but at lower doses. And we have a frontline study for newly diagnosed chronic phase CML patients where we enroll them on dasatinib 50 milligrams once a day instead of dasatinib 100 milligram once a day. And the goal of the study is to see, with lower doses, can we see equivalent complete molecular, major molecular responses while potentially seeing lower rates of toxicity such as pleural effusion, cardiac issues, fluid retention. So I think the area is under evolution, but at this time a number of guidelines, and our suggestion is probably to start with the second generation TKI.